Becky Royer, and I'm a consultant for the Indiana Hospital Association. And our next presentation is going to be a session that will provide some direction on promoting appropriate use and differences of 988 as compared to 911 and 211 hotlines. Joining us is Kara Biro, the State Director of Behavioral Health Crisis Care. She's with the Division of Mental Health and Addiction at the Indiana Family and Social Services Administration, or FSSA. So at this time, I'm going to turn it over to Kara. Hi, Kara.
Hello, Becky, or thank you for the introduction, and thank you for having me here today. I'm going to share my screen. I have just a little slide deck to share, nothing too fancy and nothing too much, but also happy to take any questions as they arise. You can do so in the chat. Let me know. Can you all see my presentation?
Not just yet.
You'll need to hit the green share screen button. It should be at the bottom of your screen.
Yep. Here we go. Okay. Let me go ahead and there we go. Now can you see it?
No. So when you hit the share screen button, click screen in the upper left corner, and then in the lower right corner, click share again. There we go. Perfect.
There we go. All right. I swear I've done this before. So as Becky stated, my name is Kara Biro, and I am the State Director of Behavioral Health Crisis Care. So it's a really long way of just saying that I won't say just saying, but of stating that I oversee the development and implementation of 988 in the state of Indiana, as well as ensuring that our behavioral health crisis care system aligns with SAMHSA's best practices. Oh, sorry. All right. So just a little, a really broad view of what 988 is. So obviously more than just a number, right? When we develop 988, we're looking at 3 pillars of the system: someone to contact, someone to respond, and a safe place for help. So what the system is meant to do is to serve anyone, anywhere, anytime, regardless of what their needs may be. And so 988 really is the focus on mental health distress and an individual in crisis. And we as the state are not identifying what a crisis is to an individual. And what's important about that is that a crisis to me is going to be different than a crisis is to you. Now, the big question that of course comes up of when do we call 988? So as I stated, 988 really is about mental health related distress. So someone who has thoughts of suicide, mental health crisis, or substance use crisis. 988 is also a free service and is confidential, so it allows the individual to stay anonymous. Our average call time in the state of Indiana is about 16 to 20 minutes. And so studies show that when an individual reaches out to a crisis line, 80% of those calls can be resolved over that first interaction through the call. Of those that are not stabilized on that phone call and require mobile response, 70% of those individuals are able to remain stable in the community with mobile response supports. And then of those that are not stabilized through mobile response and require a safe place for help, such as a crisis receiving and stabilization service, 65% of those individuals are discharged into the community, with 85% remaining stable with community supports. And so this just shows that the system, when we're able to meet an individual where they're at, when we're able to allow them the autonomy to have a say in what their journey looks like for stabilization when it comes to mental health related distress, the likelihood of them remaining in their community where they are increases drastically. So our goal with 988 is to really focus on the least restrictive and the least costly supports for an individual that's experiencing a crisis, which will lead to a decreased use of emergency departments, inpatient, and individuals being placed in jail for stabilization due to mental health crisis. And so with that, when we talk about the 911 and 211, again, 911, as we all know, is for public safety and life-threatening emergencies. There are times that with 988, if an individual is in imminent risk, we will need to reach out to law enforcement or emergency services so that we can keep an individual safe. Our goal with 988 is to work with the individual, collaborate with them, and let them know what's happening, and that the goal is to ensure safety for the individual. With 988, we do not have geolocation, so we don't know where someone is. So it really is about building that relationship and collaborating with the individual and working together to find the best solution for them to stabilize where they're at. The other piece of our mobile crisis teams is that they're required by law in Indiana to include a certified peer. Studies show that in the moment of a crisis, a certified peer is the #1 trusted individual on the scene. Secondary is EMS staff. And so really by implementing peers in our system, our goal is to increase the chances of an individual stabilizing in the community and really being able to not have to experience things such as inpatient or jail. The third resource, of course, is 211. And so there's a lot of questions about what those two look like together. And so 211 is still a great resource for everyone to connect to help and community resources. So information about if an individual needs assistance with accessing mental health or substance use treatment, any assistance, education, other lifelines like the domestic violence or sexual assault lifelines, any family services, food, clothing, healthcare. Again, a confidential service and something that's available for individuals to reach out to receive access to resources that they may not know exist to help them get through whatever it is that they're experiencing. Again, 988 is really focusing on an individual who's in crisis at that moment. And again, that individual gets to choose what that crisis looks like. I'll go to the next slide here. So what I have here is just a really quick and simple slide for you. You can scan the QR code, make things a lot easier. And this will take you to our DMHA at 988 in Indiana website. Here you'll find FAQs and information about the system as we develop it. You can also sign up to receive updates through our newsletter. And there's also an email on there for general questions that can be reached to me, can be sent to me, and I can answer those about 988 or the system as a whole. And let's see, I think that's really it. So I try to do a really brief overview, but I'm happy to answer any questions that anyone may have.
Quick question. Are there any flyers that can be downloaded and posted to make people aware of 988 and 211 in particular?
So as far as resources on the Indiana website, there is a printable resource page or resource card that you can print out or have printed. And right now we're still working on our marketing campaign. So Indiana specific material will be coming in the near future. However, SAMHSA does have a variety of resources available on their website through the partner toolkit that can be printed off. And it's just really about the 988 system as a whole nationally.
So kind of if it starts with a 9, it's crisis. If it's a 2, it's your resources.
Resources, yeah.
Yes. The next question is, there are local resources missing from 211. How do we get those added?
So 988 and 211 are two separate entities. So I would encourage you to reach out to the 211 department so you can find their information on the website. 211 has information on the indiana.gov website as well.
Okay, that's helpful to know that it's two different divisions too.
Yes. You can also share that information with me through the general email, which is I can put in the chat to make it easier, or I can send to you and you can make it, share it with everyone.
Yes, that would be good. How about other questions for Kara? Kara, that was helpful so that we can get word out that the line is available and
Yes.
people can access it as needed. So really appreciate you sharing today. Thank you so
Absolutely.
much.
And just a reminder that you can call 988 for yourself or for someone that you know. And again, the lifeline is anonymous, so you don't have to share any information that you don't want to. Our goal really is to connect with an individual, help them stabilize in the moment of crisis, and connect them to resources that are needed for them.
Okay, great, great. And she has shared that email link in chat, so please pick that up and reach out. Okay, well, thank you again. And I think at this time, I will turn it over to Don Gettinger for our last presentation, but yet a great panel that has been pulled together. So Don Gettinger is with QSource. So Don, take it away.
Thank you so much, Becky. Can you hear me?
Yes.
Perfect. All right. Yeah, this is a wonderful panel. We're going to be talking about how to maximize substance use disorder and the resources and support that are available. First, going to introduce Mr. Doug Huntsinger, who is the Executive Director for Drug Prevention, Treatment, and Enforcement, and is also the Chairman of the Indiana Commission to Combat Substance Use Disorder at the Office of the Governor. I don't think we can say enough about how thankful we are, I think, as partners and as a state for the work that Doug has been doing to try to do outreach on substance use disorder, treatment, recovery, and prevention. He's done a lot of amazing things. So I'm excited to hear him speak today. And then we're going to be joined by a panel, including Dr. Eric Yazel, who I've known for quite a while now. And I sometimes call the busiest person in Indiana because he seems like he has more jobs than anyone else I can think of. But he's the EMS medical director for the state of Indiana, the Office of the State Fire Marshal. He's also the Indiana Department of Homeland Security. Our panel is also going to be moderated by Mr. Brandon George, who's the Director of Consulting at Ascension Recovery Services. And we will also be joined by Heather Rodriguez, who is the Indiana Recovery Network Director, the Manager of Recovery Community Development, Vice President of Mental Health America and Indiana Recovery and Advocacy Programs, and the Indiana Addictions Coalition and Mental Health America. And then our final panelist is Charmin Gabbard, who is the Director of the Connections Café. So I'm going to turn it over now. I think to see who's on. I think I'm going to turn it over to maybe you, Dr. Yazel, unless we have Doug on as well. I'm not seeing Doug on the screen.
There we go.
There he is. Perfect. I'll turn it over to Mr. Douglas Huntsinger.
Good afternoon. Apologies there, some technical difficulties. The computer always wants you to update your app when you need to log on. I just want to take a quick moment and kind of talk about a recent study that we had commissioned by our partners at RTI, the Research Triangle, or they're in the Research Triangle in North Carolina. But they recently conducted a study that revealed here in Indiana that 65% of individuals who died from an overdose had visited an emergency department within 96 days prior to their overdose death. And so what this tells us, it really emphasizes that critical need for medication for opioid use disorder and is connections to addiction supports in our emergency rooms. And we know that our emergency departments are a critical intervention point, but only a handful of our emergency departments really have that comprehensive plan to address substance use disorder. And I want to be clear. I mean, we shouldn't expect our emergency physicians or our emergency departments to provide the full continuum of care, but we should be doing everything we can to connect connect and provide that connection to care. And so that's through peer recovery coaches, EMR integration, prescriber, physician training, transportation to connect individuals to community-based resources, and treatment and follow-up care are all components for the success. And thanks to the work of Representative Vermillion, this session, the Hospital Association has committed to making this a priority of the Council on Quality and Patient Safety. And our administration plans to use national opioid settlement funds to help provide resources to build on our current infrastructure that we have that will help create a system that ensures that individuals are able to access care. And so, as you look across the state, our goal is to really take a tailored approach. As you look at what works in Fort Wayne and Clarksville, it's going to look different in Paoli or Marion. And later you're going to hear some of these examples. And I think we're really excited about helping drive down this number. It's a critical intervention point for us, and I think it will go a long way to help save lives if we can provide that connection from the emergency department. So I want to thank everybody here for all you do in your communities, and I'll look forward to our future conversations.
Thank you, Doug, very, very, very much. You missed the front part. We heaped all the praise on you about the amazing work coming out of the governor's office, and how lucky we are to have you helping coordinate all these really important efforts. As you mentioned, hospitals are a key part of the infrastructure to any healthcare system, often the backbone in many, many communities. We certainly appreciate the effort in that regard, and I can't think of anybody to speak about it with more expertise than Dr. Yazel. I've had the opportunity to know him for several years, worked on multiple pieces of legislation together, and he's truly an advocate in the addiction space, the recovery space, and I think it was important to Dr. Yazel to have you talk both about the work that you've done so far, some of just the mechanics also of programs in this space. You'll be able to talk to how the hospital within a community touches with other infrastructure, like with Heather and the Indian Recovery Network, and Charmin's going to be able to really give an in-depth view of what that looks like in a community as an RCO trying to connect with resources in this space as well. So a lot of ground to cover, but if you could give us a little background on you and some of the work you've done, that would be an amazing start.
No, thank you. I appreciate it. And thanks, Brandon, for all the work you do. And Doug, same thing. And excited to be on here. Just to give you guys a little background, I'm an emergency room doctor. I work at part of my shifts at University of Louisville and their trauma center, and then the other half at Clark Memorial in Jeffersonville. And you guys have all heard the story across the state. 5 or 6 years ago, we just started seeing overdose after overdose after overdose, and I had no training or experience with substance use disorder. I knew what we were doing was wrong, and I knew it wasn't working. It was as simple as that. And I started to see, it would hit home because, Clarksville and Jeffersonville is a small enough area that, I'm seeing, friends of mine's kids and parents and things like that. And I was like, we got to do something. And, at the time I was discharging people with a phone number for a facility and patting myself on the back on how enlightened I was, and then we complained when people came back, and it's like, we're doing the same thing all over and over again. I always compare it to pneumonia. If somebody comes into the ER 6 times with pneumonia and I give them the same antibiotic, I'm not enlightened. I'm sitting in front of the CEO trying to explain why I suck as a doctor. And so I was like, we've got to put some programs in place to start, figuring things out. And, I looked at it as kind of 3 phases, from an active overdose to entry into the healthcare system, from entry into the healthcare system into stable recovery, and from stable recovery into just, back into life as a whole. And, our first priority was just to keep people alive, back then, especially. So we have a real EMS problem in our county with some long response times and things like that. So we really engaged our citizens on, public Narcan access. And we got a program called Pulse Point that would actually notify people of an overdose in their vicinity to where they could respond and things like that. And kind of a unexpected secondary effect really was impressive from a stigma reduction side of things. Instead of complaining about it, people were actively responding. We're giving them tools to intervene. And, from that point, it just helped us to continue to build things. And, I always say, when you're trying to get a foothold in your community, the first thing you should do is try to find an easy win that makes your, makes your elected officials look good. You sound like a NASCAR team. I'd like to thank the county commissioners program here and make them look good. And, and that's, I always say you shouldn't be asking them for something only when you need something. You should be trying to make them look good, show up at their events and things like that, build that trust, and then they'll start to buy into what you're doing. So that was kind of where it all started from, so that's what got me invested in it. And we've just kind of continued to build from there, to be honest.
Well, I appreciate, and I think that some of the things you highlighted, I think in the overall recovery space, we talk about these breakdown between health, home, community, and purpose, like 4 major areas similar to the social determinants, if you will, right? Do people have housing? Do they have food? Some of the things. And I think with the addiction specifically, we often don't make it past the health part, or we get stuck in that lane, which is important, right? Like we have to keep people alive, but it's also very hard for people to participate in that process. Like if they don't have somewhere to go lay their head that night, right? Like if you don't have housing or some of these kind of needs that supersede, so some other things that are needed to do well. And so, I think that the state DMHA, obviously Doug and the governor's office several years ago really put a heavy focus on recovery supports, right? Like we're getting Narcan, we're taking care of the health, we're trying to expand beds, access to medication, but really heavily leaning into, okay, well, how do we make sure people don't drop through the cracks, get recovery supports, recovery housing, et cetera. And a really big part of that has been the Indiana Recovery Network, which has been Heather Rodriguez's baby and brainchild for the last 5 years of pretty much of development with a lot of state partners. And so I know that she's spoken a little bit with some of the folks from the Hospital Association on this, but we really thought it would be good to have her explain a little bit more in depth. What's the Recovery Hubs project? What's the Indiana Recovery Network? How does it fit into this bigger picture, right? I think some people don't really know all the nuance of it. So Heather, do you want to give us a little background on and explain this to folks a little bit?
Yep, I'd love to. Thanks again for inviting me to participate in this panel discussion. And so just a little bit of, I guess, history or information about the Indiana Recovery Network as an organization. I like to refer to us as Indiana's Recovery Locator. So prior to the launch of the Indiana Recovery Network website, when individuals and even families would go online to find out about what recovery supports are available and what types of supports those even are and what they might need to access. There really wasn't just one centralized location that had all of the supports listed in our state. Oftentimes, it would pop up the treatment locators, specific treatment providers, things of that nature that really don't go beyond, the acute care and sustainable recovery. And so that's how the Indiana Recovery Network was thought of to be in existence. And so we do have a website. And we have over 100 registered members that are recovery-focused organizations. And kind of to piggyback on what Brandon said, these organizations provide services that are classified through the 4 dimensions of recovery, so health, home, purpose, community. And we also have other statewide resources that are available, again, categorized by the 4 dimensions of recovery. And so through our website, individuals can do a quick search by city or zip code and find recovery support services located nearest them. And so that could be, recovery residents, because certainly, like Brandon mentioned, having a safe living environment is critical to overall wellness, especially when you're in recovery. And then as well as that community piece and having that connection and re-engagement and support for recovery. So we have recovery centers, recovery community organizations, recovery cafes that are members, and Charmin is one of our members as well. And then through there and having the IRN in existence, when COVID hit, there was a real concern about individuals being left without access to critical support services, especially individuals in the reentry population, individuals experiencing homelessness. And our friends at DMHA and the governor's office knew about the Indiana Recovery Network and the work that we had been doing since 2018, and reached out to us to try and create a solution and help people really stay connected when, you know, a lot of our service providers were closing their doors or having long wait lists, to find a solution to maintain that connection and support. And so through the partnership, we created the Regional Recovery Hub program. And that now is 21 different recovery focused organizations who provide free peer recovery support services to all 92 counties in Indiana. And so these services, you know, because they are grant funded through our friends at DMHA, are free for individuals. So that means that anybody can access a peer support services, whether it's to find out about other resources that are available in their communities, to get ongoing individual or group peer support services facilitated by a certified peer professional, I will add. And then just anything that might fall under those 4 dimensions of recovery. And so we're able to launch that. We are now, it's been going for 3 years that we are happy to announce. And so we see the recovery hubs as really that access point, kind of like Dr. Yazel mentioned, and even Brandon, that these hubs can connect with even hospitals, treatment providers, to be that starting point into recovery. Once somebody leaves an ER, they can be referred to the recovery hub, and a peer will walk alongside them and really help them find the resources they need to experience overall wellness and begin their recovery journey, and hopefully reduce those ER visits and get them plugged into other services. And so I'll also just like to mention that our hubs do provide services for adolescents as well. So it's not just about, you know, adults. Certainly family services are available, but we do provide services to adolescents, typically 13 years and up. And so that's also a resource that hospitals can access as well. Again, no cost for those individuals. So just wanted to share that information as well.
I really appreciate it, Heather, and it spurred a couple thoughts, and you know, you talked about the delivery of peer support services. I think that we all know that there's a lack of workforce in the addiction space across the state, just in general, whether that's community mental health centers or you know, addiction treatment providers, et cetera. And while peer support aren't necessarily going to make up the 7,000 licensed professionals that we're short, they certainly can play a major role in ensuring that people stay connected and they get the proper resources that they need. I had a clinician one time, you know, ask me this, and she's like, well, you guys are just going to have all these peer supports take over our jobs and, you know, save money or something like that. And what I wanted to focus on was, you know, a lot of times licensed clinicians get caught up doing things. We want people to, quote unquote, like practice to the top of their license. Like a social worker or a clinician shouldn't, or Dr. Yazel shouldn't have to spend an hour on the phone with somebody trying to get somebody into a recovery house, right? Or get somebody a ride. We need him seeing patients, saving lives, you know, making medical decisions, et cetera. And so the hubs and the delivery of peer supports to help people stay connected during that time. And again, even a clinician, you see him once a month or once a week or whatever time period is. What do you do between A and B, right? Between this Tuesday and 2 Tuesdays down the road. And oftentimes that's peer support, getting them connected to recovery meetings or a variety of things. And I want, you know, Charmin has firsthand experience getting, you know, an organization started in a community. I want to ask Dr. Yazel something real quick, just because you talked about shifting the way that you all do stuff at the hospital. How have you seen the benefits of peer support from your end as a physician, as an administrator, like in an organization? What benefits have you seen from being engaged with peer support?
Well, I'll be honest, at the bare bones of it, they're just better at it. Also, you know, I used to think I was pretty good at having that discussion, and I've had some patients over the last few years where I just feel like I'm not getting anywhere, and then I'll bring in peer support, and next thing I know, they're getting whisked off to somewhere, and I'm like, "How'd you do that?" So, I mean, they are. I don't care how good you think you are at your, you know, at your speech, they're probably better. So, number one, it's that, and just improving that access too. I think, from my standpoint in the emergency department, you know, my work, I'm always trying to get us to where I don't care if you come in at 2 in the afternoon or 2 in the morning, I'm able to offer you the same level of service. And right now I'm still to the point where what I can do in the wee hours of the morning isn't the same. And we've been able to kind of bridge that gap with some peer support. You know, during the day, I could probably get you directly into a recovery facility. I can't at 2 a.m. And I've, you know, over and over again over the years, I would see, you know, hey, I've got you set up for admission at 9 a.m. and they wouldn't show. And I think peer support has really been able to kind of help bridge that gap, you know, navigate that a little better, maybe follow up in the morning and help them, you know, kind of nudge them towards the door and some things like that. So that's where I've seen it, at least from my end.
I appreciate that. And one of the things that also made me just think about is, you know, the peers that we've seen working in EDs and um, the stigma that helps out with as well. I think that when you've got physicians and you've got nurses and you've got other people working with people that are in recovery on a regular basis, it changes the whole dynamic. And that happens with law enforcement as well. And you know, I know this sounds silly, but like I couldn't. The first time, like some physicians and other professionals started like treating me like with respect, like I was like part of a team, like it was mind blowing for me. Like that just had not necessarily been my experience in a variety of settings. And so like just hearing you on this call and talking, you know, about how much value they bring, and like you could see your eyes light up talking about the benefits of them, made me think about that. And I really, really appreciate it. And so, you know, Charmin, you are one of my favorite people in the whole wide world, a huge advocate. And I got introduced to Charmin probably about 4 years ago from one of the administrators at a state hospital, actually, that works for the state now. Said, hey, if you guys are doing stuff with recovery supports and you're trying to help control the spread of infectious disease through certain service programs and things like that, you've got to meet Charmin. And so Charmin and her group were not part of the original Recovery Hubs project, but boy, we remedied that very, very fast. And so she's a really good example too. If you guys start thinking, you know, I think in some places people don't necessarily think of recovery organizations and harm reduction in the same space. And I'm really proud of Indiana for overcoming some of those barriers, seeing how those things can really coincide as part of one continuum. And you've been able to do so in a you know, environment that's not always conducive to that. And so your accomplishments have been quite enormous. And so can you tell us just a little bit about starting a recovery organization, some of the ways that you've got plugged in to organizations in the community, become part of that kind of infrastructure for people with addiction and trying to find recovery? And then we'll talk here in a few minutes about specifically trying to engage with the hospital system.
Thank you, Brandon. Make me tear up there. So first I want to say, like Dr. Yazel mentioned, the difference in his being able to connect that person to services. And I think what the peer brings is all those years of lived experience, and to know how important that is, and that it is from that different lens. They see it through a different lens, and it's that training that they bring to the table. And I do believe that's very important. Katrina Miller Norris actually gave me my first job as a person in recovery in a full-time position at a hospital. And we had just opened a 42-bed detox facility here in Fayette County. And that didn't last very long because the hospital ended up filing bankruptcy. So from that, we got to see a lot of different things in the way the emergency room was ran and when people were brought in through a different lens as well. And Dr. Yazel also mentioned that that relationship with the commissioners. So myself and the county health nurse was working in harm reduction, and then we took that program with us from the health department. So we took the SSP out of that health department, and then that was able to also open up our eyes to how much stigma they really, like we were seeing through the health department, where people were coming in for services, but we were only seeing maybe 15 people a week. And then when we took it out of there with us to the hospital setting, we had our own space, and services started to increase. And then when the hospital shut down, So there were a lot of barriers that we were experiencing with that. And then coming back on, I was contracted to keep the harm reduction program. And then we started working with some other entities to make that alliance, because we wanted a streamlined process if they were ready for services. And then on my end, it wasn't about like trying to push them into a service. It was about meeting the need and whatever that looked like. And then another barrier, COVID hit. And at that time, we reopened the Harm Reduction Alliance in January of 20, and then COVID hit. And so we were pushed out of that center. And through that process, I did meet Brandon George. And what I know now is that all of those issues that seemed like they were detrimental was actually what was able to launch us to where we're at, with our program. So we went to, or it was just myself at that time. And then through COVID, we still were able to meet the need of our people by bicycle deliveries and setting up tents in a parking lot. And then Brandon made a way for us to get a trailer. So we had this small trailer and such. And then he shared with us all of this about the recovery hubs and the network that they were building. And so what it was, it's sort of like we were fighting here in our community alone, because we were building that peer support within, but also not having the support of others. And then because of stigma. And then, so even though like some of us had education and recovery, and then coming on, when we got in our own space and we joined the network, and then having more guidance in that support all throughout the state, it really has launched us into just something that I couldn't even have wrote the story for if I was writing out the fairy tale of Connection Café. So today we went from seeing 10 to 15 people in that space to over 125 people weekly. And this space has grown organically. And we do cover 5 counties. And I say that as like some of the pushback that we get in our own community, where other counties are just reaching out and wanting more support. And now that to bring it around to talking about serving in those peers, putting those peers in the emergency room department, we are in a space right now working with Rush County Emergency Room Department, and they took the lead on this. So we're just trying to figure out how we fit in. And Brandon said something one time, like we are like the fire department. So we want to dispatch our peers to those spaces where we can oversee and supervise that position, but also meet the need of whatever they want from us. We have experienced a lot of knowing that locally, when our peers go, our members, we call all of our people members, but when they go to be treated for services, I'm sorry, I'm talking a lot and I always get anxiety. They don't always get treated the best, and so sometimes they just don't go to the emergency room unless they're taken in through that overdose, and they want to get out of there as quickly as possible because they're afraid they're going to be arrested. And so what we see is the re-overdose, or they take out their own IV and they leave out of fear of being arrested. And so I think one of the things that we want to see more of is those partnerships. And if that peer is there, then that peer is there to say, here, I'm here to help you. And I'm here to advocate for you. And the more that we see that, the more lives we're going to see be changed, because they have someone in their corner. And we know like our overdose rates just continue to increase, and the isolation of COVID and how that has exacerbated things. But we also know what saves lives, and that is that medication assisted recovery option. And I think Dr. Yazel and Brandon both mentioned this, that we don't want to see those, it's not the job of the emergency room to be that ongoing provider, but they are that critical access point where, given that connection and those resources, then those lives will be saved. And our peers are so passionate because they know what it's like walking that journey, and they know the stigma, and they know what it's like to not go to the emergency room because of the infections and such. And so our peers are educated, and our peers are trained, and they're all certified, and we do have those credentials, and we do have a board that oversees that. And I think those things are very important for people to know, that they're not just coming out of the street, they're coming with recovery to us, and that we want them to be their best. And so we have all of those expectations, and we answer to people above us, just like every other scope of work. And we're not here to take anyone's job. We're here to make your job easier and to meet our people where they're at and to help save lives. We want to make a difference and lighten the load, but we also know what's working from a different level. And some of those things took us many tries, and we know that the drugs that are out there right now, they don't get many tries. Sometimes it's a one and done. And we know by what the governor's office has done, and Overdose Lifeline, and helping us connect all of those resources like naloxone. Some communities don't have that, and they've been able to help us. We have 5 here in our community that are 24 access, and then we have a harm reduction vending machine. So we're here to fight, while you that have different scopes of work are there to save lives and to be able to practice for what you went to school for. And we've been training for this for a lot of years in a different area, and we're here to help those people, and they are our people. So in this space, we do have people that are in active use, and we do have people that are in 7, 8, 9, 10 years of recovery, working and coming here. And because that's what works, it's grown organically. And I think when we see that person coming in the door, and just like some of the programs teach us, the most important person coming in that door is that person in active use. And that's what we see here. And it's not about what services we want to give them, it's what services are they willing to let us walk through with them.
Sure. That was absolutely amazing. And yeah, I couldn't agree more. It's got me thinking of a couple different things. And Dr. Yazel, be prepared. I'm gonna blabber here for a second, but I'm gonna tee you up for a little bit of a discussion here. And so I think one of the things I wanted to do during this conversation is kind of set the stage about hospitals and emergency departments being able to connect with outside organizations that can provide some of the support that these high need, highly complex patients are going to need. And it's been mentioned a couple times, but I do want to drive it home. I don't think that anybody thinks that, the emergency departments need to be the person to find a solution to the states or the community's overdose problem. However, they play an absolutely critical role access wise. And so, part of what got me into this conversation was you kept hearing about, Doug mentioned it, most people that die of an overdose, they've been to an emergency department within the last 90 days. And I certainly, don't mean this as a reflection on the hospital. It's like, how could that be though? Like if they're going to the hospitals and we have our arms around them, like, how are they dying so quick? And what we're finding out is, there's a lack of services in areas, and emergency departments don't have the resources, and there's a variety of reasons for it. But I think now the question is, how do we start overcoming that? And, your big hospital systems, Eskenazi's got an amazing, peer program. They do it all themselves. They've got, opioid treatment program attached to it that they can connect to. And that's, because they're robust, they're a big system. And that's not the case in Indiana. Majority of it's rural, et cetera. But trying to make sure that our hospitals at least have, some type of plan in place to connect people. Like, okay, if I don't do medication in my ED, like what organization does do it so that I can, either have them come in or pass them off, et cetera. And so one of my very first calls, I figured out, I couldn't figure out why, if I'm being honest, why there wasn't legal liability for hospitals not giving out medication. It's a life-saving medication. I couldn't figure it out. So I called Dr. Yazel was one of my calls, and I'm like, how is this? And and it's, at this point, there's not an established standard of care around opioid use disorder in emergency departments. And so it's kind of, up to each administration or administrative office to figure out what that is going to be. And Doug alluded to it, there's a commitment from the Indiana Hospital Association to focus on this. We're having this call right now. This is kind of part of the tee-off process for all this. But, Dr. Yates, I guess my question to you, and one of the conversations we've had personally is, you've got a very kind of specific framework for a lot of healthcare issues, and that you're supposed to, kind of follow as a physician. And while it's not there, like, what all have you done to make sure that there is some type of a plan in place that you have when there's some boxes that you're checking, some things, protocols you're following when people come in, even though it's not a mandated standard of care, if you will?
Yeah, that's a great question. And yeah, I remember that conversation too, because, struck a chord with me because something that's bothered me for a long time is if you come into the ER for an overdose, you have a 5% 1-year mortality. And this isn't talking about, nursing home patients or something like that. These are young, typically healthy patients with a lot of life in front of them. And if it was any other condition, I mean, you'd have billboards and mobile teams and we'd be circling the wagons and, every resource under the sun would be thrown at it. And honestly, there are standards of care that I think should be in place for these kind of things. We've talked about this before and that's what we're trying to go through with some of that legislation that's come there is, I do think you don't have to do MAT, but you should have a referral process in. You should, you should be able to have access to some sort of peer recovery coach or something. All those things should be standard of care, just like when you come in for a heart attack. I get a little paper and I check the boxes of all the things I did that are standard of care for that heart attack. I should be able to do that for my overdose patients. And we've tried to, even though that's not something that I have to do, we've tried to approach it with that same mentality, to be honest with you. And there is one thing, and I think Charmin made a good point. Almost everybody who's in recovery can tell you they've had an adverse healthcare experience, a lot of times in the ER and things like that. And so, I think just improving on that and saying, and showing them, by going through all those motions, like, you're important to me, this is an important condition. My rates of people, pulling their IV out and storming out, it's gone way down over the last few years. And I'll even ask, I'll say, in a perfect world, what sort of recovery option would be available to you that you think you would be successful in? And then I sit there and listen to them talk for a while. And number one, I get tons of valuable insight, but also shows that I care and I'm trying to work with them and find them the right avenue there. But one thing I think we could do as a recovery community too is circle back on the back end. I always say right now, when somebody collapses on a ball field and they get defibrillated and they run to the cath lab and everything works as it should, that patient comes back to the ER like 6 months later and everybody's high-fiving and everybody feels good, have a little extra spring in your step when you see a chest pain patient. We don't do that with people in recovery, and we really should, because I think that would help with compassion fatigue and something like that. I would love to see a patient come back to my ER and say, you know what, you Narcan'd me 6 months ago. I'm in stable recovery now. I've got a job or whatever that life looks like at that point. And I think that would do wonders for a lot of ERs on that type of mentality and improving the healthcare experience for those patients.
What a really, really great point. I think that one of the things that I've found over the years of working specifically with law enforcement and hospitals is that you guys are the safety nets for public safety and then for public health. And you all oftentimes see the same people over and over and over again. And it, regardless of, just because you experience compassion fatigue doesn't make you a bad person, right? Like, anybody can get frustrated with the situation in general. And so, to your point, having folks working, having relationships, I think community-wise too, with your local RCO or your recovery place, makes it easier for that to happen, to have people in recovery come in, et cetera. And you do get some of that. This is why we're doing it, right? This is why I Narcan Brandon 8 times, because, now he gets to participate in raising his daughters, and he went back to school and all of the things, and it gives you some purpose behind it. And part of that conversation is the connection, I think, with the hospitals. I've had the pleasure of working with Heather and Charmin on getting recovery organizations up and going. And we have had, and Heather, this is going to be a question for you. Some of the very first parameters around kind of becoming a recovery hub was making specific community connections, right? Getting together with community corrections, making sure that whoever provided MAT you had a relationship with, and kind of being part of that stakeholder group. The hospitals are complex systems. They're very, very intimidating. It's my experience with them. They're sometimes hard to engage because there's lots of layers. Heather, have you seen, I guess kind of twofold, like, what have some of the things been that have helped establish relationships for RCOs, like having meetings with, or MOUs, more formal stuff, or like, what have some of the people done to try to connect with places like hospitals or community mental health centers to build those relationships up?
Yeah, I would say that it definitely takes time, patience, and perseverance to even get those going. And it looks different for the different hubs. And certainly I think geographic location plays a role in that. And so, we've seen it where it starts as just a simple like emailing, going to the actual location. And we'll say CMHCs, for example, right? Dropping off flyers, trying to request meetings, things of that nature, until there's actually some partnership established and there's a successful kind of referral process. And so I know for some of our hubs, it could take anywhere from like 3 months to even over a year, well over a year, I will say. But once those partnerships are established, I think a lot of it in the early days is just kind of educating, right? And so kind of like to piggyback on what Charmin and even you said, Brandon, like explaining what the role is of a peer, right? We are trained and certified professionals. We don't provide clinical services. We're not trying to take anybody's jobs. We just want to be complementary to the services that you are already providing. And so in some cases where it's limited services, right, they can connect with a hub or a peer at the hub to get ongoing support services, or in conjunction with the services they're already receiving. And so it takes a lot of time and effort to even get that going. And then we've seen it where the hubs have established MOUs or memorandums of understanding. And so what's the expectation? What's the role of the hub and the peer? And on the opposite side of the service provider they're partnering with, we have seen a few, and I want to say less than a quarter, have established actual contracts and paid contracts. And I think when we talk about like hospitals or clinical providers, the real concern is protecting personal health information. And what does that look like? And there are definitely some barriers, I think, from the administrative level within the different systems. But just because there's barriers doesn't mean we're not able to overcome those challenges, right? I think it's a lot of education, a lot of open communication, and understanding that, the information that we collect, it is in a cloud-based service. It is protected, password protective. The participants have to even agree to having their information stored in the system and even shared, right? And they can refuse that as well, right? And so just having that information and being transparent about the work the hubs do, who peers are, who they aren't, and how at the end of the day, like the other panelists have said, the goal is just to save lives and help people find sustainable recovery, whatever that looks like for them.
I appreciate that. And I think that, hospitals are very, multifaceted organizations are established, and a lot of the recovery organizations are new, spry, young, growing, developing organizations. They don't have the traditional infrastructure that some other partner organizations would have, like say EMS or some other traditional partners. And so overcoming some of those administrative barriers that you're talking about, I think, is important. Like we see this even getting peers into EDs, like background checks. Like there's actually some laws in place that prevent employees of hospitals if you have theft charges, unless you're like actually a licensed physician or have some licensure attached. And so there's some benefits there to using recovery organizations. You bypass some of that regulation, but having a firm, you mentioned MOUs, Heather. I think that's important, right? I think that both parties really want to know what is this relationship look like? What can I count on the other side when I do make a call to Connection Café? Like what actually is going to happen? And then on the other end of it, I'm going to call back within whatever 30 minutes or an hour when I get it, or we're going to do something on site, or we do something on telephone. And so having those established relationships, I think, is critical. And And that's for any referral source, having some type of process in place that's more than like, yeah, like I'll give you a call if somebody comes. Like, no, what's the actual process look like if we're going to start engaging in this together? And Charmin, I know that you've developed those relationships in a lot of spaces. Have you found anything to be more helpful than others, or that have worked out well for the parties involved?
So we're currently in the process of building that MOU right now with Rush County, and everything that you just mentioned, the privacy protection and then the handoff. And so by May 5th, we have agreed to have that in place so that we can launch this, and we will have a peer on call out of Rush Memorial, and then it is at our expense, which is something that no matter what, we're willing to take one right now, because to be able to work through this is going to be able to bring it to other entities. But it's just been a lot of communication with them, and Rush County's been wonderful in that connection with Joyce Philmorth, that through the state. She's been amazing. One of the things that we were discussing was the app that Indiana Recovery Network provides, where having that instant peer, where they can have that connection through the emergency room department, and then they can connect with our peer on call and for that handoff. And then from there, we will, depending on what the situation is and if that person what their status is. We know if it's someone like presenting with psychosis from meth, that it's going to be hard to get them into something immediately. So we have those, that's what we're working on currently. But if it's in an overdose and they're not going to come and take them to jail, then, and they're ready for treatment, we're going to come, we're going to sit with them, and we're going to get them connected and stay with them. So those are the things that we're looking at, is like on our end, this is what we can provide and what their expectation is from us.
Thank you. I appreciate that. And so I want to pause. I want to make sure that we have time for questions. I know it's been a long day, everybody, and we're going to get out of here. We're going to wrap shortly, but this is it's a complex space. We've got some folks on from the hospital administration side, from the recovery community side, from the administration, the governor's office on. What questions do you have, whether it's a broad philosophical question for the state, or whether it's more of like a nuts and bolts Dr. Yazel question? Feel free to either get in the chat box or the Q&A. I don't think folks can unmute themselves, but if you want to put a question in the chat box, we will be happy to answer. One thing I did want to mention is, Heather mentioned there's 21 recovery hubs in the state. They cover all 92 counties. So regardless of where you're at, you do have a recovery hub that services your area. The one thing I will say is, some of them, Charmin I'll use her as an example. She's on, they cover 5 counties. Not all counties are going to have the same intensity of services. Probably her main county and maybe 1 or 2 more she's going to be really involved, and she's probably going to triage the other ones, right? Like she's going to answer calls, she's going to help connect people, but she's not necessarily going to have resources to put people in all 5 of those hospitals. And so it really becomes an effort on multiple fronts, right? The county commissioners helping out, the hospital possibly helping out. The highest cost way to treat somebody is through the emergency department. And so if we can use a fraction of that money to save the cost, it's well worth it. We see a lot of hospitals do it. In my new role in West Virginia, there's a hospital called Mont Health, and they're paying for peers in all of them because it's cost saving. It helps people and it's cost saving. Like it's just they need to get those people out of the emergency room beds as fast as possible to save them for people, that have life and death issues. And so a couple thoughts. Any questions coming in? I don't know if Don, if you've seen anything or if anybody's pinged you.
Sure, Brandon, I've got a question for you. I mean, one thing after hearing about this and learning even more today, and maybe each of the panelists can talk about what they see as the biggest barrier that they see to more hospitals adopting these services. And then what's the message that they think will help make a difference to hospitals that are struggling?
So anybody want to jump in on this? I've certainly got a few thoughts, but I'll see if anybody, See Doug or Dr. Yazel unmuting right this second. So I think resources is one of them. I think so other things, I think notoriously hospitals don't really do behavioral health services, right? And that's kind of an area that we start getting into. This is outside of, we've siloed off addiction care from our regular general healthcare system. It's not part of our hospitals. It's really not part of primary care. Like it's really been siloed off, which has created a lot of these problems inadvertently. And so now as we look to expand these and get, primary care, doing medicine again and getting emergency departments helping out, I think that there's going to be a massive educational curve is one of them. I think resources is one of them. Dr. Yates, I don't know how true it is in your hospital. I think a lot of hospital systems do contract out services in a lot of areas of expertise. We're not just talking about addiction, but if you have somebody that does specific heart stuff or maternity stuff or infant stuff, that they have partners that they'll do. And so I think we need to look at that as an option in this space. Well, as we don't have to have the specific hospital do it. It can be contracted out, but I think education and resources, I think resources are a big part of it. I know me and Doug have talked to a lot of hospital systems. And they're like, hey, we want to help, we want to do stuff, but we need resources. We need to train people. We need to get the infrastructure built. And with that we're going to kind of be stuck. Asking the hospitals to just come up and do all this on their own isn't a fair ask, like at all. So Dr. Yazel, Doug, either of you two got any comments on that?
Go ahead, Doug. I feel like I've been talking a lot, man.
I mean, I think you're absolutely right. I mean, a lot of hospitals have a lot of communities just have capacity issues. So whether that is, being able to hand people off to the appropriate treatment provider, which come this fall, that will be a little easier with a program that we're launching. But also, it's that ability to make sure that you have the right partners. I mean, I'm sure Dr. Yazel sees this. I mean, you have someone today come in with opioid use disorder, and tomorrow it's polysubstance and methamphetamine, and you're constantly looking for that sort of right place to send someone, and that's not always within your community. There are barriers with transportation, there's insurance issues, and so just a lot to navigate. And I think that's where our hubs are really important in providing that network. And then many of our especially our smaller hospitals are staffed with contract emergency departments, and that's a challenge. When you don't have consistency within the department, you don't have consistency within those partnerships. So there again, just as our solution is very localized and individualized to each and every hospital, the problems are localized to each and every hospital.
Yeah, I was going to say something very similar. That's a great point about having, like, I've been in my hospital for 20 plus years, and I still have trouble keeping track of all the options and getting the person to the right place. And, you look, especially a lot of our rural ERs, like you said, they're contracted out, or, they're not from there. They might work, one day a month there, and expecting them to understand all the options in the recovery community is, just not reasonable. We've tried to come up with some documents like a QR code that we can constantly update, so you can hit this and it's got the most up-to-date information, and encouraging people. It's somewhat helpful, but even then we have trouble keeping up sometimes. And kind of on that same line, I mean, you talk about contracting out for specialty stuff. A lot of times I'll see somebody with a broken arm, I put them into a splint and say follow up with ortho the next day, and they usually go. When you're thinking about recovery, this is a right now. You need to get them in the door if they're willing. Yeah, your time frame is very narrow. You need to get them through the door right that minute. And that's the challenge, is trying to get somebody in the right place, immediately, and things like that. And yes, all those other barriers come through, because even if it's 5 to 6 hours, somebody may be very well intentioned, but then they walk out of the ER and life gets in the way and things like that. And putting on the EMS hat there, that's where we've tried to bridge that somewhat with some of our mobile integrated health and community paramedicine programs that'll go and do follow-up and kind of eliminate that transportation barrier, at least, to have somebody on scene to help them navigate that process, after the fact. So.
Really good points. And shout out for the 211 Lyft partnership with the hubs and what the hubs do with 211. Doug talked about both of you talked about transportation actually. And so the local recovery hubs have a Lyft program that can give people rides to both treatment and recovery related stuff. Actually, anything that's to do with recovery. So it's not just for, I need a ride to treatment. If they need a ride to recovery support meeting or food pantry for a day, et cetera, they can help out with that. And so that's another way that you can refer to that local hub, as Doug was mentioning too. All right. Any more questions? What do we got? We've got about 10 minutes left. If anybody has any questions, I'm not in the business of holding people hostage necessarily, but do want to get questions answered.
Jackie or Kathy, do you have any questions?
I don't at this time.
This is Kathy, and one of the things, especially in the rural communities, is how do you get the judicial system on board? And I think there's a lot of struggle in the rural community and the stigma associated with it. I just would like to hear some suggestions.
So, yeah,
I'll
Doug,
start
please.
with that one. Yeah.
Yeah.
So every county has a local justice reinvestment advisory council, and that's where you find the justice collaborations taking place. And in some communities, that is where the larger collaboration is really centered. And so I would start with reaching out to JRAC, really talking to them and engaging them on the sequential intercept model and looking at how we can even use our hubs, our emergency departments as part of that intercept. There are people who, don't need to end up in our jail and are much more appropriate to end up at one of our hubs or end up at an emergency department, as a conduit to connect them into those community-based supports. And so we have collaborations all across the state where, our sheriffs, local police departments, judges, prosecutors are all coming together to really have a real true conversation about, is this individual appropriate for a different placement at this point in the system? And that's really what the sequential intercept model is looking at, is there a better place for you than where you're currently at? And so that involves, the arresting officer, that involves prosecutor diversion programs when you're before a judge. All of these decision makers, it's one of the challenges that you have in dealing with the justice system is there are multiple different decision makers who at different point are the lead decision maker. And so getting a community all on board is a lot of work, just like getting the medical community on board is a lot of work, but there are also a lot of connections between the two as you move forward. So I would say JRAC is the absolute place to start those conversations.
The other thing I'd say is when I'm trying to make an argument of, something's just the right thing to do for a patient, I don't feel like I'm making much headway. Then I start going through the wallet, and if you can show them some of the cost savings from some of these, all of a sudden they'll start coming around again. Then all of a sudden it's the right thing to do for the patient, but if you can get some figures together, it doesn't take too many interventions like Doug's talking about for these programs to be very cost effective. And sometimes people who can only think, in concrete forms like that, that's the way to reach them. So I try to compile some of those stats.
It's true. I mean, we were using it in reference to the hospital system, but jails are super expensive too. The cost of housing somebody in jail is very expensive on a community. The healthcare costs that the county commissioners have to put up to cover people inside of a jail are very, very costly. And so there's a lot of reasons that make some of these other interventions the right way to go. And so getting connected with the local JRAC is absolutely the way to go there.
Brandon, I just want to add something. I think stigma, she mentioned stigma. And then for me, I think like the stigma piece is just a lack of education. and understanding that when we're able to talk about that, substance use disorder is a chronic illness, and without treatment they'll die. And then instead of looking at it as a choice, but then the other opposite side of that, like law enforcement, that's their job, is to arrest. And so the thing that I try really hard to do is build those bridges with law enforcement and to try to understand their side of it. And the same with the paramedics, like they do see our same people over and over and over. And then I think what Dr. Yazel mentioned earlier is bringing that, when that individual that finds their recovery pathway, where they can see that person and making that difference, and that they were able to save that person's life. I today have a story with our local law enforcement, and I thank them because they saved my son's life, and because of that, I'm going to be a grandma come August, and my son's found his pathway of recovery, and all those that know me know that I speak openly today about our situations. But and if it wasn't for law enforcement giving him that Narcan that day, you know, he wouldn't be here. So I do think that's very important, but also we have to be more open-minded about all of these different sides of this thing, that it's not just the recovery side, it's not just that person's side of the substance use disorder, and understanding the why, that everyone that, you know, has that ability to overcome their struggle if they get support and resources. So for me, harm reduction is about building bridges with all entities and trying to be more open-minded. The stigma is a lack of education. The more we're able to help educate and people understand it is very complex, but we can do it. And I think that's why working together and allowing peers to show what we can do or how we can help is very important. So yeah, I just want to add that.
It's great. The same way Dr. Yazel mentioned, you know, folks coming back. Like, I think that's important in the the justice setting too. I think it's important for judges to see the people that are having, you know, families and participating and paying taxes and having jobs and all those things as well. And cops too, right? Get tired of arresting the same person. It's good to see them when they're doing well. You know, those emergency departments, and you see people on their worst days. Law enforcement, ED docs, like those are like massively bad days for people, and you don't get to see them on the positive days always. So that's a great way to wrap it, Charmin. I appreciate everybody. I really appreciate the Hospital Association. You guys letting us have some time today. This is a big topic. It's going to be a big topic for the next however many years, the foreseeable future. And just a big shout out to panelists, as always, Doug Huntsinger in the governor's office, Dr. Yazel, Vice President Heather Rodriguez, and Director Charmin Gabbard. I appreciate all of you very, very much. Don, I'm going to pass it back over to you.
Thank you very much, Brandon. This was a wonderful panel. I really learned a lot listening to you and just enjoyed the passion that you shared. So I'm still hopeful that we're going to continue moving forward in Indiana. Thank you all. It's now time to wrap up our day. I want to remind everybody to please complete a short evaluation for our event. It really does help us make these events meaningful to the critical access hospitals throughout the state. Becky has posted a link into the chat, but we'll also be sending out an email. There are two $25 gift cards that are raffle to hold for those that complete the evaluations. If you're not interested in those, you can check a box on the evaluation to take your name out of the raffle. But again, I can't stress enough how important those are to us that help us make the future events. I want to thank all of our speakers today and all of you who attended and are providing wonderful care for our patients in rural communities throughout the state of Indiana. This is what it's all about, and I'm glad you were with us. I think the only other thing I have to say, the evaluation, May 2nd is going to be the cutoff date for that evaluation period, and that's when the raffle will be held. Other than that, thank you so much for attending. Have a great day, and we look forward to seeing you at our next meeting.